In biochemical tests, one of the specific tests for primary hyperparathyroidism is to check for urine calcium by creatinine clearance. Now, this ratio should be more than 1 in case of primary hyperparathyroidism. This is important to rule out familial hypocalciuric hypercalcemia. Now, in case of secondary hyperparathyroidism, there is a test known as Casanova test. So, what happens in Casanova test is there is selective venous sampling for parathyroid hormone in neck and brachial vein on side of graft. So basically over here, if the ratio is greater than 20:1, it is a sign of a recurrent disease. Now coming down to the treatment part in primary, secondary and tertiary. For primary, if it is an adenoma, which is the most common pathology found in the primary, we do a minimally invasive surgery. The size of incision should be less than 3 centimeter. Now, if there is a discordant imaging and failure to identify the pathology, in that case we do 3.5 gland parathyroidectomy with auto transplantation at brachioradialis. In case of secondary, renal transplant is only the definitive treatment. The therapies that can be used to bridge the gap include sinacylate, now which alter the set point of the calcium receptor. Now in case of tertiary hyperparathyroidism, we need to do a subtotal parathyroidectomy or total with autotransplantation, and here use of calcimimetics is controversial. Now in this we would add the indications of surgery in primary hyperparathyroidism. So age, it should be less than 50 years. Then in case of skeletal, the T-score should be less than 2.5 at minus 2.5 at lumbar spine, total hip, femoral neck and distal 1/3 radius. Then renal, it should be creatinine clearance less than 60 ml per minute Then 24-hour urinary calcium should be more than 10 millimole per deciliter, and there must be increased risk of stone formation. Now, the serum calcium level must be more than 1 milligram per deciliter above the upper limit of normal. Now, there are few more points that need to be added in the secondary hyperparathyroidism. Here, there has been some role in the pathogenesis of fibroblast growth factor 23, right? And in case of clinical features of primary hyperparathyroidism, it is often said that it is catabolic at cortical site, like distal 1/3 of radius, and anabolic at cancellous site. Which is the lumbar spine. So let's revise the important points of the primary and secondary and tertiary hyperparathyroidism. Now, in case of primary hyperparathyroidism, increase in PTH level, which is the defect in parathyroid gland. In secondary, increase in PTH level, but there is a normal gland. There is a systemic hypocalcemia, which is mainly due to chronic renal failure. In case of tertiary, there is autonomous activation post-renal transplant. In case of secondary hyperparathyroidism, there has been some role implicated of fibroblast growth factor 23. The most common pathology in case of primary is adenoma, whereas in case of secondary is hyperplasia. The classical description of primary hyperparathyroidism is bone, stone, abdominal groan, and psychiatric tones. It is catabolic at cortical site, which is distal 1/3 of radius, and anabolic at cancellous site, which is lumbar spine. The most important way to differentiate primary, secondary, and tertiary is the biochemical analysis, which would be the parathyroid hormone, which would be obviously elevated in all the three. The calcium elevated in primary, low in case of secondary, and high in case of tertiary. The phosphate levels would be low in case of primary, high in case of secondary, and low in case of tertiary. Vitamin D would be high in primary, low in secondary, and low in tertiary. Now, there are some important specific tests with respect to the primary hyperparathyroidism, where urine calcium and creatinine levels should be more than 1 to rule out the familial hypocalciuric hypercalcemia. The Casanova test, which is used to detect the recurrent disease, having a ratio greater than 20:1 in the serum PTH level from the serum taken from the PTH from the neck and from the grafted arm. Then the treatment in case of primary would be a minimally invasive surgery of less than 3 centimeter incision in case of adenoma, whereas if it is a discordant imaging, you need to do a 3.5 gland parathyroidectomy along with autotransplantation at brachioradialis. In case of secondary, the only definitive treatment is the renal transplant. However, to bridge the gap, sinacelit can be used, which altered the set point of calcium receptors. In case of tertiary, it is a subtotal parathyroidectomy or total parathyroidectomy with autotransplantation. The use of calcium mimetics over here is controversial. Now, there are some indications of surgery in primary hyperparathyroidism, where age is less than 50 years, skeletal, T-score less than -2.5 at lumbar spine, total hip, femoral neck, and distal 1/3 of radius. For renal parameters, creatinine clearance should be less than 60 ml per minute, 24-hour urinary calcium more than 10 millimole per deciliter, and increased risk of stone formation. And the serum calcium level must be more than 1 milligram per deciliter above the upper limit of normal. So you would be getting a question from this particular topic, like the indications of surgery in primary hyperparathyroidism, where which of the following is not the criterion. Most often they change the question of age less than 50 years to age more than 50 years, or they may play with the values of the serum calcium levels or the creatinine clearance. Now we would end this topic of hyperparathyroidism by discussing few small topics, which are persistent hyperparathyroidism versus recurrent. So what is persistent hyperparathyroidism? That is elevated calcium level within 6 weeks of surgery intervention. Now what is recurrent? It is 6 months after surgery, but with intervening period of normocalcemia. Intervening period of normocalcemia. So let's again revise this. The word persistent, that means the hyperparathyroidism has not been corrected. It is elevated calcium within 6 weeks of the surgery intervention. Recurrent, so it has happened after surgery and there was a normal period of intervening normocalcemia, and it is 6 months after surgery. Now there is another important topic with hyperparathyroidism, which is because of lithium induced hyperparathyroidism. This is basically due to the long term usage of lithium. It causes gland hyperplasia. It may be associated with adenoma, say in approximately 33 to 49% of cases. Now, the biochemical abnormalities resolve with discontinuation of lithium. So if you stop the drug, the biochemical abnormalities that would be present with lithium-induced hyperparathyroidism would be solved. Now, minimally invasive surgery is contraindicated over here, as it is usually a multi-gland disease. Excision limited to glands obviously enlarged at exploration, and not a formal 3.5 gland dissection. So these are the few important points that I would like to remember for lithium-induced hyperparathyroidism. It is due to the long-term usage of lithium. It is associated with gland hyperplasia. Adenoma may be associated in around 33 to 49% of cases. Biochemical abnormalities resolve discontinuation of lithium. Minimally invasive surgery is usually contraindicated as it is a multi-gland disease, and excision should be limited to glands obviously enlarged at exploration and not a formal 3.5 gland excision. Thank you.